So far, we've discussed a lot of aspects of the pulmonary artery catheter that really should serve as a good base of knowledge when you're caring for patients that have them. So with that in mind, let's go ahead and talk about some important aspects to managing patients with PA catheters. Alright you guys, welcome back to another video lesson from ICU Advantage. My name is Eddie Watson, and my goal is to give you guys the confidence to succeed in the ICU by making these complex critical care subjects easy to understand. I truly hope that I'm able to do just that, and if I am, I do invite you to subscribe to the channel down below. When you do, make sure you hit that bell icon and select all notifications so you never miss out when I release a new lesson. Alright, in this lesson we're going to take a look at various aspects of managing these patients, from some important things to remember for the setup, along with insertion and position verification, and then some aspects of our monitoring and assessment that we need to do. So to start off, let's quickly review over some of the important things to know when we're setting up a PA catheter. So first, when it comes to tubing, we know that we're going to have at least 2 lines that we're going to be transducing. Now, while we can use individual pressure tubing lines, they actually have these kits that are like a 3-in-1 kit that are designed specifically for PA catheters. They've got 1 spike for 1 pressurized bag of fluid, and then that splits off into 3 lines. We've got our RA CVP, our PA, and then the third one is for ART line. Now, they certainly are nice as they are more organized, and they either have pre-colored parts and stopcocks, so like blue, yellow, and red, or they have stickers that we can apply to the transducer and the lines to easily identify which is for what. Now with these, we still prime each line individually the same way that we would do any other pressure tubing. And then typically we're going to be continuously transducing the RA CVP and the PA lines. Now the pulmonary capillary wedge pressure is obviously something that's obtained intermittently with the inflation of the balloon, assuming that your facility allows you to do this. Now we could intermittently do the RA CVP line, but at a minimum, the PA line must always be transduced. And the reason for this is we need to ensure that we don't go into a wedge and then cause infarction or possible damage to the pulmonary artery, as well as we need to know if it pulls back into the RV. Obviously, we have ectopy and things going on, but this way we would know what the cause is, and it's something that we could easily correct. Now, depending on the capability of your catheter, you're probably going to need some other pieces of equipment. So if it has a thermistor to record temperature, then there's going to be a cable to send that back to the monitor. If you have a thermistor, then more than likely you're also going to be doing cardiac output measurements. So if you are fortunate enough to be utilizing a continuous cardiac output swan, then you're just going to need another cable, and it's usually combined with the thermistor one to connect from the monitor to the catheter. Now remember that it's this specific wire that actually sends power to the filament to actually heat up on that swan. Now, if you're doing the intermittent bolus thermodilution, then you're going to need the whole setup for fluid with the 10 ml syringe for administering that bolus. Now, all this can be done and set up manually, but typically there's a prepackaged kit that has everything together. We are going to need a separate bag of fluids for this, and this is not going to need to be pressurized. And remember that this is going to be attached to the RA CVP line. We're going to have a 3-way stopcock there to close off to the pressure tubing when we're shooting our cardiac output. We're also going to need another cable that's going to do the temperature monitoring of the fluid that's being infused for shooting our cardiac output. Now, when we're doing the intermittent bolus thermodilution, it is important that you get the proper computation constant programmed into your monitor. So real quickly, I'm just going to show you an example of part of a chart that has some of the Edwards swans with their different models and associated computational constants. So what this is it's actually a number that adjusts the algorithm in the computer that's used to do the calculation for cardiac output. The way that it does this is it's looking at the thermodilution curves and the time it takes to change temperatures, and this is going to be affected by the size of the catheter and how quickly or slowly you're able to actually infuse fluid. So this computation constant, it actually factors in the size of the catheter, as well as the starting temperature of the fluid that's being infused to ensure that the algorithm actually calculates the correct cardiac output. So make sure you get that inputted in there, and then also when you're coming onto your shift, you want to verify that this number is actually correct in your monitor. Now again, this only applies if you're doing the intermittent bolus thermodilution. If you're using a continuous cardiac output swan, that already factors in everything that it needs to know. All right, now from there, you may also be monitoring a continuous SVO2. So remember that we can get an SVO2 intermittently by drawing a VBG from the PA port. That said, for the continuous monitoring, as you guessed, you're going to need another cable specifically for this. And then once the swan is placed, we're actually going to need to calibrate the SVO2 reading to ensure its accuracy. To do so, there's an option to calibrate on your monitor. It's often listed as something like in vivo calibration. We're going to select that, and then basically it remembers the values that it records from the fiber optic line on the swan at that moment in time. Now at that same time, we're also going to draw off of the PA port and then run a VBG from there. Now the monitor is going to kind of hold itself in this standby position, remembering those last values, and so once we have the VBG ran and we have the SVO2 value from that, then we come back in, we plug that number back into the monitor, and then it calibrates itself to that value. Now this SVO2 is going to need to be calibrated at regular intervals. Usually once a shift is best, but at least once a day at a minimum. We may also want to calibrate if there's been a significant loss of blood. It's a pretty quick and easy process to do it. Alright, so now let's talk about the actual insertion of the PA catheter. Now, oftentimes this is something that's going to be done in cath lab or in the OR, and the patient's going to come back to you with a swan already in place. That being said, this absolutely can be done, and often enough is done at the bedside. So when you're assisting with this, it's really important that you do know those different waveforms, which is going to help to guide us through the placement, and calling them out can often be helpful to the provider that's floating the swan if they happen to not be looking up at that moment. Typically, they are going to be watching the monitor as they're floating the swan, and so one thing that's really helpful is you can actually put the monitor into either the wedge setup or look for a larger setup for PA catheter insertion. And basically this puts your PA pressure nice and big on the monitor. And remember those waveforms, what they look like, and the order that we're going to go through them. So when we first get the catheter in there, so we know we're going to start off with the CVP, end up in the RA, so we're going to see our RA CVP waveform like we see here. And then from there, as we progress into the right ventricle, we're going to change our waveform into an RV waveform. And at this point, ectopy may be present here. Sometimes having that balloon in there in the ventricle can cause irritation, which can start to throw PVCs, have runs of VTAC. It often doesn't happen initially, but if we kind of futz around in there for an extended period of time, that's when that will really come about. That is happening. We've got two choices. We can either continue floating past that and get into the pulmonary artery and get out of the right ventricle, or we can deflate the balloon and pull back out of the RV back into our RA. Now, like I said, if we're moving on from the right ventricle, then next we're going to end up in that pulmonary artery, and so here's the waveform that you would expect to see for that here. Now remember for our RV that we have that upward sloping diastole versus our PA where we have the downward sloping diastole. And then finally from here, assuming that we're doing this, that we'll end up wedging that inflated balloon into one of the smaller pulmonary artery branches, and therefore we would see our waveform change into this one here. So again, it's really important that you're able to identify these changes in the waveform. When you see them happen, call them out on the screen. That way if the provider's not looking, they can be aware and continue to float as they're doing. And while this is all happening, you're going to be in charge of either inflating or deflating the balloon when the provider asks for it. So typically we're going to start deflated. We're going to insert the catheter. Once we're about 20 centimeters in, at that point we're going to inflate the balloon. And for the most part, we're going to leave it inflated short of any major issues until we get wedged and we know that we're in a good wedge. And then at that point, we'll take the balloon down. Now, prior to the insertion and floating, you are going to want to make sure that you have everything prepared. So obviously you're going to need your swan catheter. You're going to need the introducer sheath. You're going to need the swan protective sheath. You're going to need your pressure tubing, which you want to have primed, leveled, and zeroed and all ready to go. Obviously, you're going to need pressure cables for that tubing, and then other cables such as for your thermistor, CCO, or SVO2. And then have everything set up and labeled correctly on your monitor. Again, that's going to be really important, especially as we're monitoring that PA pressure during insertion. And then to begin everything, obviously the introducer sheath is going to need to be placed before we can float the swan in, if they don't already have one. And this is going to be just like assisting with any other central line insertion. Alright, so now we've done our insertion, but how do we know that it's actually in the correct spot initially, as well as moving forward? Well, we primarily use the waveform to determine proper placement and proper placement for wedging. So once we're wedged, we deflate the balloon, ensure that we have a pulmonary artery pressure waveform again, and then from there we want to reinflate the balloon to ensure that we once again get a good wedge pressure before we finally deflate that balloon for good. Now our whole goal with insertion of this PA catheter is we want to end up in something that we refer to as lung zone 3. So this is essentially the lower dependent portions of the lung in the larger proximal branches of the pulmonary artery. So having it in this spot, what this does is it actually ensures that we have accurate readings coming from the left atrium to our wedge pressure. So basically, if we end up in zone 2 or 1, then what this means is we actually have constriction of the various capillary vessels. And this is not going to give us an accurate reflection of our left atrial pressure. Now, all that said, we can initially be in a good spot for being in zone 3, and then we can have things that change with our patient. So increasing PEEP, blood loss, hypovolemia from diuresis. These things can change the condition in which our PA catheter is resting in, and we may no longer be considered zone 3, and therefore suddenly our values are no longer accurate. So the way that we can really identify this as a potential thing that's happening is typically our wedge pressure is going to be slightly lower than our PA diastolic, but if suddenly we have a jump up in our wedge pressure, and especially if that jump up now has it higher than our PA diastolic, and then combine that with damping of the capillary wedge waveform, that this may actually be an indication that we're no longer considered zone 3, and therefore we're not going to be able to use this to accurately gauge our left atrial pressure. So be on the lookout for that, because we can see a jump up and you might end up with a wedge pressure now of 25 that makes you think suddenly you need to diurese your patient, when in fact that's probably not what actually needs to happen. Alright, so once we have the proper position and that's been established with the waveform, then we want to make sure and lock everything into place and get the reading for the length of the catheter. So on our PA catheter, there's a series of both thick and thin lines that tell us the length that it's inserted. So as you can see here, we have a thin line that this comes about every 10 centimeters, while here is a thick line that we're going to see every 50 centimeters. And so starting from the tip of the catheter, it works its way back, one thin line, 10 centimeters, two thin lines, 20 centimeters, and works its way getting higher and higher as we get closer and closer to the hub of that catheter. Now that said, for proper positioning of most PA catheters, we're typically going to be in the 50 to centimeter range. So just a couple quick examples to go through here real quick. So let's say you're looking at your PA catheter, and here you've got 3 thin lines. How far would this be inserted? Well, hopefully you remember that a thin line is 10 centimeters, therefore 3 of them would be 30. Now once again, here's another example where we have 1 thick line and 1 thin line. So how far is that? Well, remember, 1 thick line is 50, plus we're going to add 1 more thin line, which is 10, so that takes us up to 60. And then finally, here we have 2 thick lines. How far would this one be? Well, hopefully we're not this far in. This usually doesn't happen, but this would put us at 100 centimeters. Now, from there are no other markings between our thin lines, so we really just have to make an estimate measurement of where it's at in between the 2 thin lines. Now, I've actually heard of people measuring the swan at a couple different locations. We can measure it at the last point that you can see it before it enters into the transducer, And then there's other people who will also measure it at the point at which it is inserted into the skin. Now, make sure that you're following the proper protocol at your facility, but really we should be going at the last place that we can actually read and see the reading instead of making, sometimes it's almost another 5 to 10 centimeters from where it goes into the sheath until where the insertion site is, and so you're making a big estimate if you're using that as your measuring point. That said, really the most important thing is that everyone's measuring the same and that we're all using the same process. All right, and then finally, we'll also use an X-ray to confirm placement and ensure that we are actually in a dependent portion of the lungs. And this X-ray will also show us if we're in the right or left pulmonary artery. That said, most of the lines, especially those that are inserted into the right IJ, which tends to be the most common place that we do these, typically these are going to end up in the right pulmonary artery. All right, so quickly I'm going to show you a couple examples of PA catheters on X-ray. I'm actually going to do a whole separate quick breakdown on reading the X-ray, the different parts specifically relating to our PA catheter. But basically, here's an example of a patient that has a swan that's going to our patient's right pulmonary artery. So as you can see, I'll trace along the PA catheter here. You can see it coming down the SVC. It's passing through our right atrium here, then through our right ventricle here. Then now it's into the pulmonary artery, making the turn towards the patient's right pulmonary artery, and then we can see it terminating in the dependent portion down here. And then quickly, here's one more X-ray. This time it's showing us, if we follow the path along here, that we are just into the left pulmonary artery, which you can see from the tracing of the line here. All right, and so lastly, I did want to mention about a few things to keep in mind for our ongoing monitoring and assessment. So first off, you want to quickly check and make sure that the protective sheath is locked. So there's primarily two types of protective sheaths that you'll see with two different types of locking mechanisms. First, and this is actually preferably my favorite, is the yellow locking position. So this one here twists on and locks into the sheath itself, which you can see an example of that here. And then from there, there's actually a twisting motion to lock the protective sheath in place. You can see it here from this picture here where there's both an I and an O. So the I is going to be our locked position, and then the O is going to be our open or unlocked position. Now from there, we have the other option, which is something where it uses these white twisting rings. Now, this one I don't like as much as the yellow one. This one has rings that you kind of bring together and twist and spin to tighten it down. And these exist on both ends of the protective sheath. You want to make sure that these are finger tightened. That said, even when you do have them appropriately tightened with enough force, the swan can still be moved. So this is part of the reason on why I don't like these. Knowing this, though, it often leads to over-tightening of this, which with this particular model, doing so actually clamps down on the catheter, and then we can dampen or even completely occlude one or multiple of our lumens. So what this really means is, if you have it too tight, you're going to have inaccurate waveforms, inaccurate values, and sometimes even difficulty flushing or infusing through the ports. Now from there with our assessment, we do want to be checking the length markings and confirming that. So we did just talk about the length, but really make sure you're constantly checking this and ensuring that nothing has moved. Obviously, we want to be keeping an eye on the dressing and the insertion site. So this is our typical central line stuff here. Make sure your dressing is clean, dry, and intact. We do dressing changes just like other central lines, so every 7 days. Unless we've got gauze under there, then we're going to change it out every 24. We are also monitoring this site for bleeding and signs of infection. Now from there, we have our level and 0, so make sure that we do get a 0 done at least once a shift. And then pretty much every time you go in the room, really just make sure you're checking the proper level and positioning of the transducers. Obviously, patients can shift around, things can happen, you just want to constantly be checking and making sure that you're in the right spot. These transducers are going to be in that same phlebostatic axis, just like we have with our arterial lines, which I discussed in a previous lesson, which I'll link to up above here. Also, while we're frequently in there, just do a quick square wave or fast flush test to ensure that we have accurate readings. Now from there, we do want to ensure that we have appropriate waveforms. Now we want to be checking the waveforms and really ensuring that they're appropriate for what's going on with your patient. We also want to be monitoring for any sudden changes that could signify a problem. So if you haven't already, make sure you do watch the lesson in which I talked about both our normal waveforms as well as the other lesson where I talked about the alterations that we typically see with these waveforms. So I will link to both of those up above as well. And then finally, we want to make sure that we're recording values. Oftentimes, these are just going to come across to our charting system, but you might have your cardiac output, cardiac index, and your SVO2 that may be on a separate monitor and need to be entered manually. So at least every hour we're going to be doing this, if not more often, depending on the situation. Also, if you don't have a CCO, the continuous cardiac output, then you're going to need to shoot your cardiac outputs. So this should be ordered at a desired frequency, but at least every 4 hours, if not hourly. Sometimes we do them more frequently, and certainly we'll shoot them when things are changing with our patient. Do remember, though, that for this, every time you do this, you're giving them a 10 ml bolus of fluid. Obviously, in our cardiac patients, given fluid is not always the greatest, and this certainly can build up over time. Now, once you get the cardiac output and you get your either wedge pressure, or you can use your PA diastolic if you're not wedging, we can plug these numbers into the monitor and then run our calculations and get the full set of values that I talked about in that previous lesson of normal hemodynamic values. Again, this should be done at least every 4 hours, if not more often, depending on the circumstances. All right, we covered a lot of information in that lesson. I tried to get through it as quickly as possible. I feel like I could go on for days and days and days about the PA catheter, but we are getting close to finishing up this series here. I have just a couple small lessons left. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.